Thank you all for joining. I am Deanna Gerber. I'm one of the gynecologic oncologists on our Long Island campus. We have an amazing panel of speakers today. All are passionate about the prevention, detection, and treatment of gynecologic cancer. And so without further ado, we'll start with Dr. Emeline Aviki, who is also a gynecologic oncologist practicing on our Long Island campus. She is also the medical director for Perlmutter Cancer Center's network sites. She has non-clinical expertise in cancer care affordability, and today will be sharing with us some basics of gynecologic cancer prevention and screening.
Thank you so much, Dr. Gerber. Thank you for being a tremendous partner in our clinical practice and for putting together such a great webinar today for our patients. To any of my patients who are out there, hi, and thanks for joining us. And for others, hopefully you'll find this talk interesting. We're going to touch on prevention and screening. I have no financial disclosures. Next slide. So like I said, we're going to first discuss modifiable risk factors for gynecologic cancers and then go into prevention and screening by disease type. So we'll start with modifiable risk factors. So there are many risk factors for cancer. However, there's a limited number that we can actually control. So we like to put these into three different buckets. The first bucket is primary modifiable risk factors. These are things that we do or that we choose to do every day in our daily lives that can affect our risk for cancers, including tobacco use, our diet, obesity or being overweight, how much physical activity we engage in, and our use of alcohol. Last slide, secondary modifiable risk factors. These are things that we're not necessarily choosing to do, but that are in our environment or associated with our work. These include infectious agents, occupational exposures, environmental pollution, radiation, including radiation from the sun. Lastly, there are non-modifiable risk factors, which we'll touch on during various parts of this talk, including us simply aging, which we can't control, things that we inherit from our family members, us being women and having ovaries, so gender, ethnicity, and race. Next slide. So when we talk about cancers that develop from these modifiable risk factors, it's important to distinguish there's two ways you can develop cancers. One is hereditary cancers, or you having a pre-existing mutation that then leads to you developing the cancer. And then there's a sporadic development of cancer, which is really the cancers that have been influenced by those modifiable and non-modifiable risk factors. So if you think about those two different types of cancers, if you inherit a mutation, then at birth, just by being born and having that mutation, that's your first hit. And then throughout your life, you have other exposures that can increase your risk, and then you develop the cancer. For sporadic cancer that develop, you're born as you are without any predisposition, and then you encounter things during your life that then cause those mutations and cause you to develop cancer. So we really want to minimize those sporadic cancers that develop. One of the causes that was modifiable that we discuss is obesity or being overweight. This is a big problem in America today that is actually worsening over time. The top line is adults and the bottom line is youth. And this shows that this shows the percent of adults and youth in America that are overweight. And as you can see, the most recent figures are increasing, and it was 37% for adults and 17% for children. And when we look at obesity by state, again, obesity is when you have a BMI that's over 30, and BMI it's a calculation that's based on your weight and your height, essentially. If you look across the United States, you can see New York in the top right screen, and we're yellow. So about 25 to 30% of us are obese, which is actually much better than other parts of the country. So not perfect, but we're doing okay. Next slide. There are many health consequences of obesity, which Rebecca Guterman is going to give a nice talk on that includes obesity and diet and things that we can do to modify this risk. So I'll let her, go into the weeds with respect to that. But what's important for us to take away is that obesity increases our risk of endometrial cancers, breast, colon, kidney, gallbladder, liver, even ovarian cancers. And what's really important is when we are obese or overweight and we are diagnosed with a cancer, we're much more likely to have complications associated with the treatment of that cancer. So it's really something that should be a primary target for prevention. Tobacco use is another modifiable risk factor that increases risk of many cancers, including for the GYN land, cervical and vulvar cancers. It's no surprise to anyone that cigarette smoking kills more than 480,000 Americans each year, 41,000 deaths from exposure to secondhand smoke. It's very costly to us as a country. Smoking related illness costs more than $300 billion annually, and 15% of US adults are cigarette smokers currently. So if we could do one thing to really try to bend the curve of new GYN cancers being diagnosed, tobacco use reduction would significantly do that. Alcohol is another risk factor. Alcohol is a known carcinogen, and it is that by increasing hormone levels, decreasing absorption of vitamins, and also breaking down into free radicals, which cause inflammation and cell mutation, which then causes cancers. Alcohol has been associated with an increased risk in head and neck cancers, esophageal cancers, liver cancers, breast cancers, colorectal cancers. Really, there are more, but these are really the cancers that it significantly increase the risk of. Next slide. Now, stress. Chronic stress can also increase your risk of developing cancer by weakening your immune system. So there are two graphics that we have here. The first shows the bottom line in blue shows normal, healthy stress levels. And the top line in orange shows our average stress levels, which, as you can see, are not healthy levels, but they have been getting healthier. So stress reduction is huge through meditation, exercise, healthy sleep. The second graphic shows differences in stress levels by gender, which is really important when you think about GYN cancers. So the top the top line shows women's stress levels, and then the bottom is men. So women in general have higher stress levels than men. And what's concerning about this figure is that the stress levels, while they're going down across the board, the gap between men and women is actually widening. So something that we should pay a bit more attention to and try to decrease as much as we can. Next slide. All right, so those were the modifiable risk factors that I wanted to touch on, just things that in our everyday life, everyone asks, how can I reduce my risk of cancer? What are the risk factors for cancer? Those are really the highlights. Now we're going to do a deep dive and just touch on prevention and screening, what we know about prevention and screening for each of the GYN cancers. Next slide. So today we'll touch on 4 GYN cancers. We'll touch on endometrial cancer, cervical cancer, vulvar cancer, and ovarian cancer. Risk factors for endometrial cancer. Any situation that increases estrogen levels in your body is going to increase your risk of endometrial cancer. If you look at the picture on the right, you can see the lining of the uterus, which is called the endometrium. This lining is particularly sensitive to estrogen. I tell my patients that estrogen is like watering the grass. It makes it grow, grow, grow. And then as it grows, it can mutate, become a precancer, and then a cancer. So anything that increases the levels of estrogen in your body is going to increase that. So that includes obesity. Obesity increases estrogen in the body by causing the conversion of other hormones into estrogen, which happens in the fat tissue. And so women who are obese or overweight have a higher level of estrogen, which can then feed that lining, make it grow, 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 mutate, and then a cancer can develop. There's other risk factors, for example, hormone replacement, tamoxifen use in women with breast cancer who are using it to decrease the risk of the breast cancer coming back. Age, of course. Genetics are a major factor also for uterine cancers. There's a syndrome called Lynch syndrome, which is a host of different mutations that can increase your risk genetically. It's inherited from families. So knowing if a family member of yours has had endometrial cancer and getting genetic testing can also be helpful. So it's also important to note that there's no reliable screening for endometrial cancer. And this, unfortunately, is a theme for GYN cancers. So what's really important is that you pay attention to symptoms and know the symptoms that you may have a precancer or cancer of the endometrium or uterus. And that is abnormal bleeding. It's sometimes the only sign we get. And so I always will tell my patients, family members, if you've gone into menopause and you have even a little pink tinge on Easter when you were really stressed out, that is a reason for you to go and see your doctor and have an evaluation for those symptoms. And that evaluation might include an ultrasound. And ideally, we always like to have a biopsy as oncologists. Postmenopausal bleeding is huge for patients who have not gone into menopause. If you're having heavy or abnormal bleeding and there's no great explanation for it, a biopsy is worthwhile. So talk to your gynecologist and just, get the biopsy so that you can confirm that there is nothing going on in terms of a transformation into precancer or cancer. All right, so that wrapped up our endometrial cancer. The one thing we didn't touch on there is just if you have a family history of uterine cancers or of colon cancers, talk to your doctor about getting genetic testing, because if you do have a mutation in one of the Lynch syndrome genes, we would prophylactically remove the uterus early to prevent you from developing that cancer. So now we'll move on to cervical cancer. Cervical cancer, the main risk factor is really this virus called the human papillomavirus. So there are low risk strains that don't cause cancer, but cause unsightly warts. That's strain 6 and 11. And then there's high risk HPV strains that can be associated with high grade precancer and cancer of the cervix. And those have grown in number over the years. Other risk factors for cervical cancer, these are mostly things that either increase your risk of getting the HPV virus. So early onset of sexual activity, multiple sexual partners. It's a very common virus. So there really shouldn't be any stigma associated with it, but we know that it's passed on through intercourse, through sex. So if you've had more sexual partners, you're more likely to have it. Next category of things that increase your risk for cervical cancer is things that suppress your immune system. So if you have a condition like HIV or a condition that is like an autoimmune condition where you have to use steroids, that can suppress your immune system and increase your risk of developing cervical cancer. Again, and cigarette smoking also falls in that category of immune suppression and can increase your risk of developing cervical cancer. It's important to know for many of you who have the HPV virus, there's no reason to be alarmed. All it means is that you need screening. It takes about 10 to 20 years for the HPV virus to actually develop into a cervical cancer, which gives us a beautiful window to make sure it never happens. But as long as you go and see your gynecologist and get appropriate follow-up, it really should be able to prevent you from developing that cancer. Again, on the topic of prevention, we have screening guidelines for pap smear or for cervical cancer screening, which include a pap test, which collects cells, and an HPV test, which tests for the virus. The testing starts at age 21, and every 3 years from age 21 to 29, you get the cytology or cell sample only. Every 3 to 5 years from 30 to 65, you get both the cytology or cells and the virus sampled. And then there's a protocol that you follow based on the findings from those pap screenings. Now, if you've had a history of an abnormal pap smear, it needs to have been normal for 20 years before you stop screening. Testing after 65, if you've had all normal pap smears, is not necessary, but I do tell my patients, if you have intercourse, if you have a new sexual partner and you're over the age of 65, it makes good sense for you to resume your screening. And then if you've had a hysterectomy for reasons that do not include abnormal pap smears or cervical dysplasia, then there's no indication for screening after that time. Again, for prevention, getting the Gardasil vaccine, which vaccinates against the HPV virus, is the best thing you can possibly do. So tell your nieces, your nephews, your children, your friends, if you're between the ages of 9 and 45 and you have not had this vaccine, it is important to do so to prevent from developing cervical cancer. And even after you get this vaccine, you still need to get a pap test and do pap screening per the guidelines. Vulvar cancer is very similar to cervical cancer. Again, risk factors include the HPV virus, a weakened immune system for the reasons we just talked about, tobacco use, a condition called lichen sclerosis, which is an autoimmune condition of the vulva, condyloma or warts, and age. As we get older, our risk of vulvar cancers increase. Vulvar cancer prevention. The key to this is really, really simple. Annual GYN visits where a vulvar exam is performed and you knowing your own body. So monitor symptoms. If you have new itching, swelling, pain, a mass or a growth in your vulvar area, take a look in the mirror. Don't be shy. If you see it there, go to your doctor and tell them about it. They'll likely want to take a core biopsy, which we have photographed here. It's a simple procedure. It's done under local anesthesia in the clinic, and it can tell us whether or not you have a problem, and so that we can address it. Additionally, women who have this condition called lichen sclerosis, it's an inflammatory condition. It's autoimmune. It requires the use of steroids. If those steroids are used, you prevent the development of cancers over time, but it does need to be treated in order to do that. Risk factors for ovarian cancer. Any factors that increase the number of ovulations you have in your lifetime are going to increase your risk of ovarian cancer. So this includes if you haven't had any pregnancies. Pregnancies will protect you from ovulations for an average of 12 months. And so if you have none, then you ovulate all those months and it increases your risk. Family history is critical for ovarian cancer. People who have family history of ovarian cancer or breast cancer who then get tested may have the BRCA1 or 2 mutation or some lower penetrance or moderate things that are considered moderate penetrance mutations that are less likely to be associated with ovarian cancer, but still require us to intervene to reduce your risk. Also Lynch syndrome, which we talked about earlier, associated with endometrial cancer. Other risk factors are increasing age, endometriosis, and protective factors, which are important, oral contraceptive use. If you used a birth control over time, it likely stopped your ovulation for a period of time, and that reduced your risk. Also, having your fallopian tubes removed, this term called salpingectomy, can decrease your risk, and having more pregnancies can also reduce your risk. History and exam findings that are concerning for ovarian cancer, mostly this is abdominal discomfort and bloating, which is about 50% of patients who present with that. GI disturbances, urinary changes. Most of these symptoms are associated with more advanced stage disease. Unfortunately, the symptoms, you should talk to your doctor if you experience any of these symptoms, but in most cases, the disease is already advanced. And what is really unfortunate is that we still do not have any reliable or effective screening tests for ovarian cancer. So monitor for your symptoms, know your family history, and get genetic testing if indicated. And if you do have a genetic predisposition to developing ovarian cancer, then we will likely do ultrasounds and CA-125 tests every 6 months. However, we know that this is not shown to be effective. What's most important is that you get risk-reducing surgery at designated ages based on whatever mutation you have. So this wraps it up. The summary is healthy lifestyle choices will help with preventing gynecologic cancers. For endometrial cancer, weight loss, prompt evaluation of any abnormal bleeding. For cervical cancer, it's the only cancer that we have where we actually have effective screening. So let's take advantage of it. Get your routine pap smears, HPV vaccines, don't use tobacco. The same is true for vulvar cancer. In addition, treat your lichen sclerosus. And lastly, for ovarian cancer, know your family history, get genetic testing if it's indicated, and then monitor symptoms.
Is resolved HPV still a risk factor?
Yeah, this is a great question. This is tough because, HPV can become dormant over time, and therefore it won't be detected in our routine pap smears. But in a patient who's had a history of HPV, what's really important is that you continue to get routine pap smears. If you continue to get routine pap smears, and there's an algorithm that we follow closely based on your history, then you should be safe. In most cases, it will lay dormant for decades even, but it can relapse. And if it does, we just want to be ready. And if you've been doing a routine screening, you should be safe. Why do 6-month ultrasounds and CA-125 if it doesn't catch early ovarian cancer? This is a great question. Everyone doesn't do it, but a lot of people do. The reason why, there's no good reason. So we don't have good data for it, but it can sometimes make us feel more reassured. Dr. Gerber, do you want to chime in on that?
No, I agree with you. It's the best that we have. And so that's what we use in our very high risk patients with those mutations. But, the science and research continues so that we can find a really good and effective screening tool for ovarian cancer, hopefully in the future.
That's true. And, there's a couple of things you treat when you're managing patients. One is to treat the actual disease, and the other is to treat and make people feel comfortable and confident in their care and their condition. And sometimes doing a quick ultrasound and doing a blood test can give someone reassurance that they haven't felt for the last 6 months. And sometimes that's worth it. I just went off tamoxifen after 5 years, and I just had a mastectomy. Is my risk lower because I'm off the tamoxifen, or the same because I was on it? So tamoxifen is really tricky. When you're on tamoxifen is when your risk is highest for developing cancers of the inner lining of the uterus. But it is also, it's also a drug that it's called stromally active. So it's also active on the muscular layer of your uterus. Typically, women who are diagnosed with uterine cancers from tamoxifen are diagnosed with those cancers while they're on tamoxifen. So in general, as long as you don't have any abnormal bleeding, you should be safe. But again, any abnormal bleeding in the future, prompt evaluation, and you should be taken care of. A lot of providers are now doing 10 years of tamoxifen. So I'm glad that you're off after 5. But it worries us as GYN oncologists, extending it to 10 years because of the risk of the uterus.
So next up, we will have Rebecca Guterman speaking about the importance of nutrition and exercise in cancer care. She is a registered dietitian and clinical nurse manager at the Perlmutter Cancer Center, and she will be giving her talk on nutrition for better health.
So Dr. Aviki went over a lot of wonderful information, and I will dive a little bit deeper into some more of those primary modifiable risk factors and steps that we could take to control some or to change some of our behaviors to improve our risks. Is one of the most common cancers, and as Dr. Aviki said, excess body fat is one of the strongest factors that can increase the risk for endometrial cancer. So a diet that is high in sugary foods, sugary drinks, processed foods that are high in carbohydrates, all of those foods can increase the risk if we're eating those in excess over time. So something that we want to think about when we are consuming those foods. So things that we could do that would help reduce the risk would be daily moderate physical activity, drinking coffee. So in some laboratory studies, some coffee components displayed strong antioxidant properties that may prevent DNA damage, improve insulin sensitivity, inhibit glucose absorption in the intestine, all of which may reduce risk. So not a strong finding, but just something worth noting. And then, of course, something that has been a strong finding is really maintaining a healthy weight that can lower the risk. With cervical cancer specifically, so there's no strong evidence linking any aspect of food, nutrition, or physical activity to reduce the risk of cervical cancer specifically, but following a lot of the healthy eating guidelines that I will mention a little bit later will help as well. Ovarian cancer, next slide. So again, maintaining a healthy weight can lower your risk because excess body fat increases the risk. And as Dr. Aviki also mentioned, obesity influences the levels of hormones and growth factors. So this could promote the growth of cancer cells. It's also linked with a low-grade level of chronic inflammation. And this chronic inflammatory state could also promote cancer development. So we do want to watch our body weight. So putting this into practice. So of course, unfortunately, we will not be able to stop all cancers from happening. And cancer prevention means reducing the number of newly diagnosed cancers worldwide that would otherwise occur. So for those already diagnosed with cancer, the same cancer prevention guidelines can help reduce the risk of other chronic diseases like type 2 diabetes or cervical cardiovascular disease. It could also, following these guidelines, can also decrease the risk of cancer recurrence, and it could influence the risk of developing a secondary cancer. So it's always a good time to take ownership of the choices that can affect your health. So we have a few different ways to assess body weight. Dr. Aviki did mention BMI, which measures height to weight. It does not accurately take into account body composition or lean muscle mass. Waist circumference is another factor to determine health risk. So really looking at these different assessments in a bigger picture. So thinking about your own body, did you gain weight recently? Did you gain weight in the last couple months, in the last couple of years? Knowing your body, noticing changes, maybe saying it is time to make some healthy changes. All of these things will likely help either achieve a healthier weight or maintain a healthier weight if you are there already. A balanced plate can definitely help. So filling your plate with 2/3 plant foods and 1/3 or less of animal proteins. So this definitely encourages a colorful plate, as you could see in the picture. It encourages plant foods, foods that are grown from the earth, and minimizes animal proteins. It doesn't completely eliminate them, but definitely taking some of the focus off of an extra large portion of protein is going to be a healthy choice. Being physically active. So we think of exercise, of course, as physical activity, but I like to encourage people to think of purposeful movement. Anything that you're doing to move your body can be physical activity. Do you love to dance? Put on some music and move around a little bit while you're cooking. Are you vigorously cleaning the bathroom? That counts as physical activity. Any way that you're moving your body is beneficial. So get up, move around. You're doing yourself good by doing any activity. But the guidelines do state aim to move at least 30 minutes per day, 5 days a week. And they do encourage moderate forms of exercise, things that get your heart pumping a little bit, maybe make you a little bit short of breath. Something that is moving your body in a way that will do that is going to be the most beneficial. So eat plants. Look to have a diet that's filled with colorful foods, vegetables and fruits. Eat the rainbow. There are so many benefits to eating fruits and vegetables that it sometimes sounds very elementary to tell people I'm speaking with to eat your fruits and vegetables, but there's so much science behind why they're healthy for you. Really, any food that comes from the earth that has been minimally modified, but between it growing and you eating it, those are going to be the best foods for you. So you could see nuts and seeds in the picture. You could see raw fruits and vegetables. I'm trying to highlight whole grains. Those have been less processed than refined grain products, so are going to make a healthier choice. So some tips to help you do this, help you achieve these goals. So stock up on canned beans when they're on sale. Canned beans are perfectly healthy. We do want to rinse them off to lower the sodium content, but otherwise a great source of plant proteins. Keep a variety of whole grains available. If it's safe for you, maybe just start with a small amount from the bulk bins, but maybe trying a new grain will encourage you to eat more of it. Finding one that you like, of course. Keeping frozen vegetables available. There's no excuse to not have a vegetable at your meal if you have them stocked in the freezer. Maybe you see something new at the farmer's market. Give it a try. You buy one, very low risk to that. Substituting one meal a week with beans and legumes as your protein source is a great way to increase your plant intake. Again, nuts and seeds. You do want to look for roasted and unsalted varieties, but you can make your own snack mix for an easy on-the-go snack. So again, research does show a diet filled with a variety of vegetables, fruits, whole grains, beans, and other plant foods helps lower the risk for many cancers. So we really do want to include these in our diet. So the American Institute for Cancer Research has a lot of information on nutrition and cancer, and I like to highlight their page that's called Foods That Fight Cancer. So if you want to know more specifically about cherries and the phytochemicals or the properties in those that are specifically healthy for us, go there. Things to limit, foods that are high and that are processed and high in fat, starch, and sugar. So sugary cereals, donuts, packaged cookies, all of these things, not so good for us if we're eating them regularly and in high amounts. Limiting sugary drinks is very important. Limiting alcohol is very important as well. You want to choose unsweetened beverages all the time. So again, putting it into practice. Try one new healthy habit each week or each day. Try a new exercise. Switch to that one vegetarian meal a week. Instead of hitting the drive-in, see what's leftovers are already in the freezer. Swap one can of soda for one can of seltzer. Go on a 10-minute lunch break walk. It doesn't have to be a huge diet or lifestyle overhaul, but all of these little things improve your overall health and reduce your risk for developing the different GYN cancers as well as many other cancers. So thank you very much for your attention. You also could get in touch with a registered dietitian, and all Perlmutter Cancer Center patients have access to registered dietitians. We provide one-on-one individual counseling. So those are the two phone numbers for general patient inquiries that will get you connected to the proper registered dietitian for you.
Many patients ask about avoiding all sugar. Can you distinguish between fructose and fruit and processed sugar?
Absolutely, and a great question. So I would never, ever discourage anyone from eating fruit. There are so many benefits to fruit, from the fiber, the antioxidant properties, all of the other phytochemicals that fruit provides. So different than a donut that has added sugar. So we're not going to be making a healthy choice by eating the glazed donut, unfortunately, but we will always be making a healthy choice by eating any type of fruit that you enjoy. The more variety, the better.
Next up, we have Dr. Hacker, who's joining us straight from the OR and will be going back to the operating room after her talk as well. She is a gynecologic oncologist out on our Brooklyn campus. In addition to her clinical role, she also works in a lab focused on researching the immunologic microenvironment of ovarian cancer to learn how we can better harness a patient's immune system to treat ovarian cancer. She will be talking about updates in gynecologic cancer treatment.
Okay, thanks for the introduction, Dr. Gerber, and thank you all for your patience. Okay, so this is just a slide that kind of goes over the FDA approvals over the last 10 years for gynecologic malignancies. And this is actually pretty exciting for us in GYN cancer treatment, because this is a lot of FDA approvals over the last 10 years, and particularly in the last 4 years, there have been approvals kind of across all disease types. I'm going to talk about some of these in a little bit, but I just wanted to give a brief overview and kind of show you that we are making progress in our cancers, and I think we're all excited about that. So I think we'd be remiss to talk about updates in treatment if we didn't talk about biomarker testing, which has become an integral component of integrating treatment into ovarian cancer, or sorry, GYN cancers, both ovarian and particularly endometrial. There are two types of biomarker testing that we talk about in gynecologic malignancies. And I think Dr. Aviki talked a little bit about some of this, but there's germline testing, which can be done either on blood or saliva. And this is particularly relevant to ovarian cancer, where we look for BRCA mutations or pathways in BRCA-like genes that are involved in homologous recombination or DNA damage repair. And then also some ovarian cancers are associated with Lynch syndrome, which we also test for in endometrial cancer. The other part of biomarker testing that we talk about is looking at the tumors themselves. And this can be done in two ways. The more, I guess, sophisticated way would be somatic tumor profiling, also known as next generation sequencing. And this is particularly used in recurrent and metastatic cancers, or FDA approved in recurrent and metastatic cancers. In ovarian cancer, we're again looking for BRCA mutations or homologous recombination defects. And then for all gynecologic cancers, we use this to test for microsatellite instability testing. There are other mutations or changes that we look for in all cancer types, but just for kind of brevity's sake, those are the two most common things that we look for with next generation sequencing across all tumor types. We can also look at just specific gene or protein expression in tumors. And this has been around for a really long time and is not new as a technique, but the things that we're looking for are a little bit new, and we've kind of learned how to harness them in a lot of different ways. So for all GYN cancers, we look at PD-1 or PD-L1, which is a marker of immunotherapy sensitivity or use. And we also look at mismatch repair deficiency, which again is another marker for immunotherapy use. In endometrial cancer, we look at HER2 amongst others, and this can be a marker for specific treatment options, which I'll talk about moving forward. And then the other thing that we can look at in ovarian cancer is folate receptor alpha testing, which I'm going to talk about a little bit. I did want to kind of spend a little bit more time on endometrial cancer, and this is because biomarker testing in endometrial cancer has recently been integrated into the new staging, which was published earlier this year, and is also tightly linked to the way that we think about prognosis and also treatment of endometrial cancer. And so this figure on the left came from the Cancer Genome Atlas study that was published in 2013. And it showed that there are 4 different molecular subtypes of endometrial cancer. And what we're looking at is kind of number of patients that are still surviving with that diagnosis over time. And so a flat line is very good, meaning that over time, 100% of patients are alive. And then the steeper the slope, the worse the prognosis. And we can see that copy number high, which are also known as P53 mutated tumors, have a poor prognosis, whereas these poly mutated tumors have an excellent prognosis. And so not to kind of go into too much detail, but this is what the current recommendations are, that we test all endometrial cancer for these different subtypes, and this helps us triage treatment and is also a critical component of clinical trials moving forward. We also looked at HER2, which I mentioned previously, and quite a few other genes, but I'm not going to talk about for brevity's sake. The other thing I just wanted to briefly talk about is that we've sort of gone away from chemotherapy in particularly the recurrent setting for a lot of our cancers, and are moving more towards targeted treatments. And I just wanted to highlight the different categories that I'm going to talk about moving forward. So PARP inhibitors are particularly used in ovarian cancer. Immunotherapy, the main category that we look at are something called checkpoint inhibitors. And I'll mention how they work in a bit. And those are particularly used in endometrial cancer and cervical cancer. And there's this new novel class of drugs called antibody drug conjugates, which we have data for in all gynecologic cancer types. So PARP inhibitors kind of capitalize on the fact that many of the ovarian cancers have a defect in DNA repair, and you can target that and make the cells not replicate as much, and therefore not grow, the cancer cells not replicate as much and not grow. And so PARP inhibitors are oral medications that are taken 1 to 2 times daily for 2 to 3 years. And there are 2 main types that we currently use in ovarian cancer in particular. And they are all used in the maintenance setting, meaning that patients get treated with chemotherapy in the upfront setting, or when they have a platinum sensitive recurrence, meaning that they've recurred within a certain time frame after receiving chemotherapy, and then they can get PARP inhibitor maintenance for 2 to 3 years. And this greatly decreases the likelihood that the cancer recurs, particularly in BRCA mutated or homologous recombination ovarian cancers. These have been around for a while, and so I'm not going to harp on them because I think there's some more exciting drugs that we can talk about. And so the class of immunotherapy drugs that we use in gynecologic malignancies are checkpoint inhibitors. And the way that I like to describe these is that they basically kind of trick or stimulate your immune system to fight the cancer. And so typically a cancer is pretty smart. And what it does is it has this protein on the surface of it, which engages with a protein on the surface of immune cells and turns those immune cells off. So the immune cells cannot fight cancer, cannot kill cancer cells. And that's sort of pictured in the middle here. On the right, when you have these drugs, they block that cell-cell interaction, and the immune system can then recognize and fight those cancer cells, leading to tumor regression or tumor killing. And then the final class of drugs that I wanted to talk about briefly, talk about the mechanism, are called antibody drug conjugates. And basically, they're this new class that takes highly potent chemotherapy drugs that are so potent that you can't give through the IV because they cause too many side effects. And they target those drugs directly to the tumor. And they do that by using an antibody or a protein that specifically recognizes a portion of the tumor cell or a protein expressed on the surface of the tumor cell, and bringing that chemotherapy directly to the tumor cell. Next slide. Once that antibody drug conjugate arrives, it is internalized, the chemo is released, tumor killing. And so this is where what I wanted to talk about was the specific drugs that we're pretty excited about. And so the first one I wanted to talk about was mirvetuximab, which I spelled wrong, so I apologize for that. And this is an antibody drug conjugate which recognizes folate receptor alpha, which is expressed on about a third of ovarian cancers to high levels. And what we can see is that in this particular study, about a third of ovarian cancer patients with high level expression of folate receptor alpha responded to mirvetuximab, meaning that their tumor shrunk in some capacity. And over 50% of patients had control of their tumor. So the tumor either shrunk or stayed the same size. And the duration of response was almost 7 months, which is almost a doubling of what you normally see in this particular class of ovarian cancer patients, which are platinum resistant. The other classes of, so the other updates are in endometrial cancer, and this is particularly focused on immunotherapy. So pembrolizumab, which is a checkpoint inhibitor, was recently approved by the FDA for treatment of mismatch repair deficient, or MSI, meaning microsatellite instability high tumors, and about 50% of those patients respond. And then it's also approved for treatment of patients' tumors with proficient mismatch repair in combination with lenvatinib. And so pretty much at this point, all endometrial cancer patients will get pembro, some sort of immunotherapy in some capacity, because they fall into these two categories. The other drug, which was also approved as a single agent, is dostarlimab. Again, it's used in the treatment of recurrent mismatch repair deficient endometrial cancer patients. And you can see here, this is the waterfall plot showing that these patients have prolonged durations of response with dostarlimab. So the arrows are kind of length of response, and you can see that many of these patients have pretty long responses. And then the most recent studies have shown that dostarlimab can be combined with recurrent or metastatic mismatch repair deficient endometrial cancer in the upfront setting with chemotherapy. And basically, this top panel shows that patients with mismatch repair deficient endometrial cancer patients have a much flatter, a much less acute slope with a flatter line than patients who didn't receive this drug. And so this recently led to an FDA approval, probably about maybe a month ago. So that's pretty exciting. And I think at least all mismatch repair deficient endometrial cancer patients who have advanced disease will get dostarlimab in the upfront setting. And the other thing I wanted to talk about, and I should disclose, is that this is not FDA approved at this point. So I'm talking about off-label drug use. But I would say that Herceptin, at least, is commonly used in endometrial cancer patients who have HER2 amplification. This is because these patients have a 50% less chance of dying within the first, I think it's 2 years of getting treatment. That's depicted in the right panel. And then finally, data presented earlier this summer at the American Society for Clinical Oncology meeting showed that Enhertu, which is an antibody drug conjugate against HER2, has almost a 60% response rate in endometrial cancer patients who have HER2 expression. And patients had really long responses. So over 70% of patients had responses lasting over a year. And so I think this will probably lead to an FDA approval, but it hasn't been there. It hasn't come yet. So we'll have to see what the FDA decides to do moving forward. And then finally, I wanted to talk briefly about cervical cancer. So pembrolizumab, which is a checkpoint inhibitor, is also approved as a single agent or in combination with chemotherapy for PD-1 positive cervical cancer. So PD-1 is a marker that indicates that immunotherapy or checkpoint inhibitors will work. And so many of our cervical cancer patients who are PD-1 positive will get pembro at some point during their treatment course. And there's also recent data showing that this can likely be combined with immunotherapy and radiation therapy in radiation treatment and lead to better responses. And then finally, we do have an antibody drug conjugate in cervical cancer, and this was the first ADC or antibody drug conjugate approved in gynecologic malignancies. It targets tissue factor, which is expressed almost ubiquitously on the surface of cervical cancers. And they found that 25% of cervical cancer patients responded to tisotumab as a single agent, and 60% of those patients had responses lasting 6 months, which is really great response for these patients who have a pretty poor prognosis.
Is your risk of MDS reduced after you are off the niraparib or a PARP inhibitor?
Most of the data for MDS shows that you don't develop it when you're on the PARP inhibitor. It's in the years afterwards. And most of the MDS data is actually from studies that did have prolonged treatment, and in patients who were receiving PARP inhibitors for treatment rather than maintenance. I think all the maintenance studies have shown that the rates of MDS are 1 to 2%, and so pretty low.
Yes, I agree with that. And I just want to add that in the maintenance setting, when you're using it earlier on in your treatment, the rate of MDS tends to be lower than if you're using it later on after you've seen other treatments. What is the average survival for stage 3 ovarian cancer with these treatments?
Yeah, I mean, we've been able to show that these treatments do prolong the time that patients, or the time that patients are alive once they begin treatment. But I don't think we have, like, mirvetuximab was approved like earlier this year or the end of last year, so it's only been really commonly used for about a year. And so I don't know that we have kind of these long-term outcomes to show that these drugs are going to prolong life, like the overall survival, sorry, for these patients. We do know that PARP inhibitor maintenance probably will lead to prolonged survival for patients with BRCA mutations. And so in the big study that looked at olaparib for maintenance following upfront treatment in ovarian cancer, specifically in BRCA1 and 2 patients, probably about 60% of patients, maybe more, didn't have a recurrence after 7 years, which is like unheard of before. So it really is kind of changing the trajectory for those patients.
We're going to let Dr. Pothuri talk about her passion, which is clinical trials. She wears many hats at NYU and at the Perlmutter Cancer Center. She is a gynecologic oncologist on our Manhattan campus. She is also the medical director for clinical trials office, as well as the director of gynecologic oncology clinical trials. She is also the associate clinical trial advisor for the Gynecologic Oncology Group Partners and the director of diversity and health equity for clinical trials for the GOG Foundation. And now I will pass the mic to her.
Thank you, Dr. Gerber. I am very excited to speak to you about clinical trials, and hopefully you will understand why they are so important in this field, and hopefully all of you will leave today sharing some of my passion. These are my disclosures. So what I want to cover briefly today is the rationale. Why do we do clinical trials? Review kind of the history of how we've done clinical trials, and then talk to you about the different types of clinical trials, and finally end on why they are so critical to our field. So what is a clinical trial? So a clinical trial is essentially any new investigation. It could be a drug, it could be a combination of drugs, it could be just any kind of clinical intervention like exercise, no exercise, or it could be a treatment. So, this clinical trials are how we get new drugs and new devices and new interventions to be our standard of care. And they can include new unapproved drugs, or they can include FDA drugs that have been approved in one condition, but may not be approved in the disease that we may be targeting it for, or it could be a combination of new drugs. And as I said, or it could be simply, a device, a new surgical device, or a new intervention such as, exercise, or a new type of nutritional supplement. So, clinical trials can take many forms. And, they do, the biggest key is that they involve people. And because they involve people, the IRB, which is the Institutional Review Board, has to approve all of these types of trials. And there are two kinds of trials that we typically speak about. Retrospective, as the name implies, is something that already happened and you're just reporting on it. And then prospective is something that is going to happen in the future, currently and in the future. And so most of the clinical trials that I'm going to be talking about are going to be prospective, although I still do lots of retrospective trials because there's still a lot to learn from those. And so why do we do it? Okay, So we do it to try to improve patient care. We are able to provide the state-of-the-art care. And, the thing about clinical trials is they take a really long time. So for instance, paclitaxel, which is a very common drug that we all use, comes from the yew tree, and it was discovered back in 1967, but it didn't become standard of care in GYN cancers to the mid-90s. So many, many years to really become, a medication that we use every day in our clinic. Why do we participate in a clinical trial? One, there are benefits to society. Clinical trials of what have brought us to where we are today. All those drugs that Kari talked to you about is because, many patients have participated bravely in these trials. And I think it's important to understand that, only 3% of patients actually participate in a clinical trial. So we have a lot of work to do here. And then, there are definitely benefits to the individual. These trials are done with very significant oversight. So, the research team and everyone who is part of this clinical trial will be watching you very closely for new side effects, and also to make sure the drug is working and that you're not having too much toxicity. So, and as I said, getting these new drugs can take many years, 10 to 12 years. So you get access to these drugs much earlier. And, the other thing to remember is most of the trials that actually make it to phase 3 are actually positive. And so, just further talking about the advantages, again, it gives you access to new drugs. You have that closer monitoring. You get to play an active role in your healthcare by, making this shared decision with your physician to go on the trial. And you may be among the first to benefit from these trials. And as I said, the upside is that most of the phase 3 trials that we run are usually positive. What are some of the minuses? When you participate in a clinical trial, and I tell all the patients this, it's a great opportunity, but really think about whether you can handle it, because, there are the schedule is very fixed, and it's really important that you keep all the scheduled visits and the appointments for your lab work, and sometimes we have to check the blood levels of the drug, and so it can add a lot of visits. So it's really important to make sure that you can handle the trial schedule before you commit to it. And then there may be unknown side effects, and so you have to keep that in mind, as well as there's a chance that this may not work. So that's why it is a trial, and that's why it is investigational. And then, as I said, a very small percentage of patients actually are on trial. And then how do you actually decide to participate in a clinical trial? So you want to think about your disease. How serious is your disease? What is the outcome with the standard of care? What other options do you have? What is the goal of the study? Is it to decrease the toxicity of a standard therapy, or is it to improve how well the drug works, over the standard? So these are kind of the important things to keep in mind. What is being investigated? Is it a new drug, or is it a new way of using these drugs? What are the risks to you? What are the costs to you? Can you handle the schedule and the logistics? Are you going to really benefit from this? Or is this really just for future generations? So I think these are questions that we each, anytime you participate in a clinical trial, you have to kind of think about and go through in your mind. So, who pays for trials? There's a lot of different ways that these trials get paid for. It could be funded through private foundations. The government funds trials. And those are mostly the cooperative group trials, the GOG, the NSABP and RTOG. These are national cooperative groups. There are special, grants that are called SPORE grants that can fund these. And then there's individual grants that are issued through the government, R01 grants. So these are all different ways that the government can fund these trials. And then industry funds a lot of the phase 3 trials because they're interested in getting new approvals and new indications. And then I think it's important to keep in mind when you're thinking about a clinical trial, the different phases and what the purpose of these different phases are. So the phase 1 are the earliest trials, and usually we're trying to understand what the toxicities of these drugs are. So, usually it's very easy to get on these because the eligibility criteria are very broad. The phase 2 trials, then, we've learned a little bit about kind of the toxicities, and now we're trying to understand more about kind of the safety of the drug, but also we're trying to understand the efficacy, meaning does it work? And then, as we get later into these phases, the entry criteria become more restrictive because we are trying to look at more and more of a specific population. And then the phase 3s, are the, trials that are larger, and they're usually comparing to a standard of care. And here, there's 2 options often. So you may not get the new drug, you may get the standard treatment, or you may get the experimental drug and there may be more toxicity. It may not be efficacious. Those are some of the cons, but you may actually get the drug that is better and has more efficacy. So, these are kind of the differences and kind of the pros and cons of the different types. And, as I said, this is just like very easy to understand. The phase 3s are the ones that, really tell us if one treatment is better than the other, and really compares it to the standard of care. And then oftentimes, these are the endpoints that we use. I don't want to confuse everyone, but with the phase 3 trials, we usually use a term called progression-free survival or overall survival. And it's really comparing one over the other, just like you would, if you were trying to pick Coke versus Pepsi or Apple versus Microsoft. So this is like simplifying it, but, we actually, it's really comparing it to a standard and seeing if the new intervention's better. And then we use a process called randomization in clinical trials. And this is really important because it takes away bias. Because, otherwise I would say, oh, well, this trial's this, I think you should go on this arm. And we can't do that, right? We have to make sure that whichever arm you get assigned to is completely random. So we understand that the reason that this is working is not because we picked the right patient for the therapy. And so, essentially randomization is like a flip of a coin or a roll of a dice. And it assigns you to the treatment group and it really takes away the bias. And it allows us to standardize the 2 groups that are being compared. And then the other thing that we often do is we employ blinding when we do these phase 3 trials. And a single blind is when whoever's participating in the trial doesn't know which treatment they're getting. And a double blind is when the participants and the treating investigators don't know which treatment the patient is receiving. And you can see why, these are important so that you're not biased about kind of, thinking about, oh, well, I think this treatment's working, so we're going to keep them on this, longer, or they're not getting the right treatment, so let's get them off trial. So it removes those kind of biases when you blind both patients and investigators to the study treatments. So, we talked about how it takes a really long time with traditional drug development, and it can be upwards of 10 years before you can really go through the phase 1, the phase 2. Sometimes you need a randomized phase 2 in there, and then you end up with the phase 3. And by the time it's accrued and you get to the endpoints, it takes almost 10, 12 years. And this has been the standard way that we've done drug development. But more recently, there have been newer strategies, and this has been because we've had a lot of targeted therapies. And so we are trying to accelerate that because we want to get new effective drugs in our patients faster. And so, we are now going to targeted phase 1, 2 trials. And then, if we're seeing signals in a very defined group of patients. We're moving that into a phase 3 and really trying to get approval faster. We've also been doing, other trial designs where we utilize things like accelerated approval, so we can, get approval earlier, and then we can have a larger phase, and you can do that based on a phase 2 trial, and then you can get a larger phase 3 trial going to confirm those findings and get full approval. So there's different ways that we are now trying to improve that timeline so we can get these new drugs and new medicines to our patients faster. And I think it's important to recognize that the new medicines are actually responsible for a 40% gain of life expectancy in the last 20 years. And then, it takes, as I said, a long time, at least 10 years for new drugs to make it. And when you start out in the early phases, not all of them make it. And the cost is is also exorbitant to really develop these medicines. And then about a third of drugs that begin in the early phases actually make it to phase 3, which is why most of the phase 3 trials that you're going to participate in usually will be positive. Not always, but they're really well vetted by that time. And then less than 5% of patients with cancer, actually participate in trials. And so, this is one of my big aims, is to really try to improve that. And then the other, disheartening piece is that, we also need to work on our active investigators, and it has declined. And again, there's a great need for increasing our investigators who do this work. Why are trials really important for the future? Because we don't always have the best treatments, and we don't understand always what the best treatments are. And we have to continually test new treatments to improve our care. It gives patients access to novel cutting edge treatments. We advanced and advancing patient care is really with both the researchers and patients. We can't do this without all of your efforts and participation. It empowers patients, and you are able to really get very structured care. And, the ASCO actually states that access to clinical trials is really a critical component of high quality care. So really, clinical trials are really important in not just the future, but even the present care. And really, without clinical trials, trying to improve, not just the longevity, but also your quality of life is very difficult without clinical trials. And, this is just kind of reiterating, I don't need to spend a lot of time, but all these new medicines and new approvals have been a result of, all our brave patients who have participated in these clinical trials. And, over the last, 10 years, we've actually had more drug approvals than in the last 50 years combined. So really goes to show you how we've accelerated that pace of clinical trials and how we are getting new medicines to our patients faster. And those were in ovarian. These are in the top we have endometrial cancer, and in the bottom we have cervical cancer advances. So again, all of these new therapies are a direct result of clinical trials. So what can you do? You can help us by raising awareness, joining advocacy groups, being politically active, lobbying for increased research and funding for not just ovarian cancer, but now even all gynecologic cancers. Endometrial cancer is, now increasing in both incidence and mortality, and is soon to overtake mortality of ovarian cancer. So really increasing that lobbying, supporting, cancer research, both locally and nationally. And, the biggest thing you can do is participate in clinical trials and help us, with this mission. So Yes. So the bottom line is, research cures cancer, and we really need, all our efforts, in terms of research, screening and prevention, basic science in the laboratory, translating that into the clinic, and then really coming up with new therapies. So it's all interrelated, and all of these things together is what is going to help us make progress with cancer care. This is our amazing team at NYU. We have our Manhattan group on the left here. We have NYU Brooklyn, Kari. We're going to get her help soon. And then we have our wonderful Long Island group. And, these are all the national cooperative groups that we partner with. And that's it. I wanted to just say that, all of these individuals at these different campuses have really been a partner in terms of developing one of the most active clinical trials programs. We are nationally recognized and in the country in terms of our accrual with GOG. And, that wouldn't have been possible without the incredible teamwork of my division and as well as the CTO at NYU. So thank you for listening.
Thank you, Dr. Pothuri. Your talk has inspired many, many questions. So I'll read them to you. But first, I want to mention Dr. Chalice, who's listening in, wanted to mention that when we're putting someone on a randomized trial, we are trained in all the possibilities and side effects of the investigational drug, as well as all of the standard of care drugs. And so we know how to manage side effects of all of them. And we're never blind about which drug you could getting. We just don't know which drug you actually are getting. Are there any encouraging phase 1 treatments for ovarian cancer happening now?
Yeah, right now, I think Kari mentioned this, the antibody drug conjugates are really, very exciting. And we have some new HER2 antibody drug conjugates that are in phase 1, and they are really exciting. So, I can't wait to really get those in further development, and so more patients can access them.
COVID vaccine was fast-tracked. Will cancer studies ever be fast-tracked?
Yeah, that's a great question. And there are a lot of drugs, there are different ways that we can do that in cancer. And, there are some fast track designations, there are breakthrough designations, and then there's, there's drugs that get priority review. So there's different ways that we can accelerate. And there are fast track designations, but and it is happening.
Is cancer research coordinated internationally to avoid duplication?
That's a great question. Many of these trials that we do through the GOG are global, meaning that we interact with our partners across the ocean. And we even include, Korea, we include Japan, as well as our European colleagues through ENGOT, our Canadian, Brazilian. So yes, absolutely.
All right, so let's move on to Dr. Lightfoot. She will speak about diversity, equity, and inclusion in gynecologic cancer. She is a gynecologic oncologist on our Manhattan campus and works at both NYU, Langone, and Bellevue Hospital. She is a health equity researcher and is the Assistant Director of Diversity, Equity, and Inclusion at the Perlmutter Cancer Center.
Thank you, and thank you to everyone who is still here with us. I'll try to wrap up relatively on time. I have no disclosure. All right, so this by no means is an exhaustive talk, but I hope to describe some of the disparities among individuals who are diagnosed with GYN cancer, highlight some of the factors that contribute to the health inequities that we've seen, and then highlight a few of the ways that might help address the GYN cancer inequities. So the National Cancer Institute defines cancer health disparities as differences in outcomes between groups that can be defined a number of different ways. So it could be the number of new cases that we see for a certain cancer. It could be the number of people who die from that cancer. It could be complications that are related to the cancer itself or treatments from the cancer, survivorship or quality of life after the cancer treatment, and then rates of screening for the cancer or stage at diagnosis. So just to highlight some of the groups that have been identified as having different or poor outcomes related to their cancer. So this could be related to a person's race or ethnicity. We know that individuals with lower SES sometimes have worse outcomes, or those who are under or uninsured. Individuals who reside in certain areas, so whether that's rural areas or territories such as Puerto Rico or Guam, individuals from our LGBTQ plus community, individuals who identify as refugees or asylum seekers, those who are differently abled, and individuals at the spectrums of age, so adolescents and young adults or elderly. I'm not going to touch on all of these, but it's just to give sort of a framework for how we might think about understanding cancer health disparities. So the next few slides are just to give you a visual about geographic distribution of disease. And again, this isn't meant to be detailed, but just so you can visually see that the where these cancers happen varies across the country and even within our own counties in New York. And sometimes, so on the left here, you see the incidence of disease in the blue, and that's just number of new cancers. So right now we're talking about cervix cancer. So you can see most of the new cervical cancer diagnoses are actually happening more in the South. And while there is overlap in terms of the new diagnoses of the cancer with the number of individuals who die from that cancer, it's not always exactly the same. And I bring that up because it's important for us to understand why that's happening. So we can go to the next slide. So different from cervical cancer, you can see that the geographic distribution for uterine cancer is very different. So now we're seeing a greater burden of new diagnoses and death from that cancer in the Midwest and the Northeast. You'll see that ovarian cancer is even more varied and is distributed more across the country. And I will say, even though I didn't present it here, this is true across our counties in New York. All right, so here I wanted to highlight some of the differences across race, and this is specific to New York. So here you can see in the blue bars, this is the new cancer diagnoses, and then in the gold bars, this is the rate of death from that cancer. And so for our patients who are diagnosed with cervical cancer, we can see that the rate is highest in our non-Hispanic Black, that's that second row of columns, and our patients who identify as Hispanic, which is the last set of columns. But non-Hispanic Black individuals are more likely to die from the disease. And so for uterine cancer, the highest rates that we see are among our non-Hispanic whites and our non-Hispanic Black patients. And again, our non-Hispanic Black patients have a higher chance of dying from the disease. And I'll highlight some of the reasons we think this happens, but again, that's a whole talk in and of itself. So for ovarian cancer, our highest rates are actually among our non-Hispanic white and our Asian and Pacific Islander patients. And I see a higher rate of death among our non-Hispanic white populations. And I'll get to this later. I couldn't present more granular data based on how the CDC presents this, but I'll come around to that a little bit later. So we know that some of these differences in outcomes are related to cancer screening and prevention, and you heard about how that's from Dr. Aviki, the importance of some of those tests, but also that we don't always have a screening or preventative measure. But certainly in cancer screening, we know that there are different rates of people getting pap smears by different identities. So, there are racial and ethnic differences in the rates of screening. There are differences among LGBTQ plus identities. And there's also differences in terms of follow-up of abnormal test results by across those groups. And then you also heard a little bit about genetic testing earlier and the importance of that. And that is important in terms of preventing cancers or understanding one's risk of cancer. Once an individual has a diagnosis of cancer, there are also documented differences in terms of cancer treatments. So those include surgery. And so we know that there are differences in terms of individuals getting their recommended surgery, the timing of that surgery, whether it's, minimally invasive or open, and, the appropriateness of those surgeries. There's also documented differences in terms of radiation treatments and chemotherapy. And then you heard a bit from Dr. Hacker and Dr. Pothuri about the molecularly targeted therapies and immunotherapy that are becoming increasingly important. And then clinical trials, which really span all of these pillars of cancer care. And I will highlight some of the disparities that we've noticed in clinical trials a little bit later. So what are some of the factors that might affect certain groups' ability to, access different pillars of care? Well, there are a lot, and they are interrelated. And what I hope you take home from this talk is that they are unique to each individual and different communities. And so we shouldn't assume that all of these are impacting everyone or that they impact individuals in the same way. So you heard a little bit about environmental exposures earlier here on the left, socioeconomic differences among groups that might affect individuals' access to care. And then clinical, so it's not just whether you have access to care, it's once you have access, is it high quality care? Is it the guideline concordant care, which just means that, you're getting the recommended treatments for a given cancer. There are cultural differences, so sometimes those affect how people interface with the health system or follow up on certain treatments or preventative measures. You heard a little bit about behavioral factors and how those affect an individual's risk of certain cancers. Psychosocial also affects how, individuals interface with the health system and their providers, but can also sometimes affect enrollment in clinical trials, for example. And then you also heard earlier about some of the biological factors from Dr. Hacker, where she highlighted, different types of testing. So there's genetic testing for hereditary causes of cancer, but also looking at the tumor itself and differences there that can affect why individuals get a cancer, how that cancer acts, and their response to certain treatments. And so this is just a representative sample. So we did some work looking at, instead of taking really broad racial categories, really trying to hone in on differences among subgroups and identifying what each group might need. And so here, this is a survival chart for ovarian cancer patients separated by their subgroups. And so here you can see that among, and this is specific to Asian groups, but we've done the same for some of our other cancers. So among individuals with ovary cancer who identified as Asian, when we split it up, you can see that there are differences across the different subgroups. And so the reason this is important is that the way you might address the barriers different groups have is different depending on the group and what you see. So just to highlight something from the last slide, when we looked at our cervical cancer patients, for example, we saw some differences in terms of, which cancer treatments they got and timing to completion. And that basically carries through to several of our cancer subtypes. One other area that I'd like to highlight as a really important area of understanding disparities, but also for future intervention, is that there have been shown to be differences in cancer genetic changes among groups of individuals. And so this is actually from lung cancer, and the AACR provided this information, but they were looking at an important mutation in the tumor among individuals with lung cancer, and basically found that the prevalence of that change in the tumor really varied by what region of the world you were from. So in East Asia, for example, which is kind of to the left center of this map, the prevalence of that specific change was about 50%. But then in some other groups, like in Africa, for example, that's only 10%. So what this tells us is we really need to involve everybody in these studies and make sure we understand what those differences are so that we can be designing the right treatments for those targets in the cancer. This is some work that our group did actually in endometrial cancer, just highlighting the same point. So these are some of the changes we can see in the endometrial cancer itself. And what we found is that some of these sort of higher risk mutations, like the P53, which is on the left, or the CCNE, which is on the far right, seem to happen more in some groups compared to others. So in Black patients, we noticed that they had more these high risk changes in their tumor compared to white patients. And that's important both for targeted therapies, but also in terms of prognosis. Here, you can really just focus on the first couple columns. So for the initial studies that happened looking at tumor changes, that was all produced through the Cancer Genome Atlas, or TCGA. And you can see here that for among our GYN patients, so particularly ovary cancer, 85% of the patients that were in those initial studies were white. And that's very different than the diverse communities that we serve. So just further driving home the importance of really understanding the nuances of our communities and being really inclusive in our this type of work in these studies. So Dr. Pothuri really did a good job of highlighting the importance of clinical trials and how that impacts outcomes. And we did a study looking at all GYN cancer. So this isn't specific to NYU. This is just historically the composition of clinical trials. You can see that especially in ovary and uterus, the majority of patients that were enrolled in trials were identified as white, and there was very little diversity otherwise. The one exception is that in cervical cancer, there was 42% who identified as Hispanic. We did look at the data comparing clinical trial enrollment to disease burden, both by number of new cases, but also number of individuals who die of the disease. And there was a large difference in terms of what you would expect this clinical trial enrollment to be compared to the burden of disease. In our study, we looked at possible inclusion factors, so these, or exclusion. So those are basically the rules that the clinical trial sets for you to be able to enter on the study. And one demographic factor that we identified was language. And so really looking at how we can, design our clinical trials to be as inclusive as possible and not use language as a factor that decides whether or not you can enter on a trial. Okay, so just kind of in conclusion, highlighting some of the areas that I think we can work on. So the first and foremost is disaggregating cancer data. So that basically means instead of putting people in these big groups, really understanding how people self-identify, and then from there being able to have a better understanding, working with communities, of what is keeping each group of people from accessing the care they need to have the best outcomes. And then once we understand on a more detailed level where those barriers are happening, focusing on interventions to make sure everybody can get guideline concordant care. Also increasing the genetic testing and tumor sequencing so that that's something that everyone has access to. We're working a lot on redefining kind of how clinical trials are carried out and being as inclusive as possible. And then the last couple, so collaborative research programs and funding, this, essentially working with our community partners and focusing our research to look at questions with community involvement and really supporting those collaborations between the community and academic centers to make sure we're meeting the needs of all of our communities. And then increasing diversity in cancer training. This is a whole other talk, but knowing that individuals who come from diverse communities continue to serve those communities and offer unique perspectives. We really need to keep working on diversifying our cancer workforce. I hope I have at least shown you that some disparities exist. Again, this was not exhaustive, and convinced you that the reasons vary by community and that our intervention should involve our communities and also be tailored to the needs of each community that we serve.